Hi, I'm going to go over renal function and some renal disease, and hopefully you'll have a greater appreciation of our wonderful little kidneys. The objectives of this talk is to really talk about the renal system and how it supports homeostasis, the glomerular filtration system, some of the terminology used when talking about kidney function. We're also going to talk about some chronic and acute kidney disease and a little bit about prevention and a little bit about treatment. The kidney has 5 main functions. One is to maintain fluid balance. The second is to help maintain normal blood pressure. The third is it's real important in RBC production. It keeps our bones healthy by making an active form of vitamin D. It's also very important in the calcium phosphate balance, and it controls pH level as far as like the metabolic aspect of acidosis. Okay? You know it's an important organ because we have 2 of them. If we lose one of them, then the other will grow in size and compensate for the loss of one. There's a little bit of vocabulary I want to talk about when relating to kidney disease, and this is reabsorption, and that's the movement of water and solute from the kidney back into the circulation system. And then secretion is the movement of solute and water from into the nephron. I am going to show you a short video now for kidney disease. And I have no idea why my computer is doing all these little noises.
Shaped organs which are located close to the back. Each kidney receives the blood flow from the renal artery, which branches off the abdominal aorta, the main artery which runs down the center of the body. Blood passes from the kidney into the vena cava via the renal vein. The ureter allows the flow of urine from. The functional mass of the kidney is divided in the cortex and medulla, which are made up of intertwined tubules called nephrons and collecting ducts, and also blood vessels. We pass through the cortex. There are approximately 1 million nephrons in each kidney. Here we focus on one, showing the renal corpuscle and the extending tubule. The Bowman's capsule is a cup-like structure which surrounds a glomerulus, a network of blood vessels. The blood vessels act like a sieve, filtering the blood that passes into the kidney. The filtered blood, which we call filtrate, passes into the tubule, is then processed by the nephron and will ultimately become urine. Each tubule divides into the proximal tubule, the descended limb of Henle's loop, the ascending limb of Henle's loop, the distal convoluted tubule, and the collecting duct. We will now look at the transport of sodium and water in each region by traveling through the nephron. Tubule initiates at the Bowman's capsule. 65% of filtrate moves from the proximal tubule back into the blood. This process is called reabsorption. The movement of water occurs secondary to that of sodium and other osmolytes. The movement of sodium from the tubular fluid into the cell is mediated by a battery of sodium-coupled exchanges, which move sodium and hydrogen in opposite directions across the cell wall. Consequently, the reabsorption of sodium largely occurs in exchange for the secretion of hydrogen into the filtrate. Water reabsorption occurs through the water channels aquaporin 1 and 7. The nephron leaves the cortex and descends into the renal medulla. The reabsorption of water and sodium are separated. This happens because the ascending and descending limbs of Henle have different permeabilities for water and sodium. The descending limb of the loop of Henle has a relatively low permeability to sodium but a high permeability to water due to the presence of aquaporin 1 channels. In the ascending limb, sodium, potassium and chloride are transported from the luminal fluid into the cell via the co-transporter in a ratio of 1 to 1 to 2. 10% of sodium reabsorption occurs in the distal connecting tubule through the sodium channels ENaC and NCC. This region does not have aquaporin water channels and therefore its permeability to water is low. Here, sodium leaves the filtrate, but water does not. The duct is responsible for the fine-tuning of sodium reabsorption. The movement of water and sodium from the lumen to the blood are under the regulation of vasopressin and aldosterone, which are released depending on whether the body needs to conserve water and sodium.
Okay, that was a really good video kind of explaining and showing some of the workings of the nephron. And so we're going to look in that a little bit further. And hopefully a lot of this is review for you. This is a cross-section of the kidney. I think this should be familiar to you, especially from your gross anatomy classes in the past. This is a breakdown of the nephron in its placement within the kidney. You see the Bowman's capsule, the glomerulus, the ascending convolute or the proximal convoluted tubule, the descending loop of Henle, the loop of Henle, well, there's all the loop of Henle, but the descending branch, the ascending branch, the distal approximated or convoluted tubule, and then the collecting duct. So some of the important parts of that they talked about during the film is the difference in where water leaves and enters the nephron. So, and this is kind of portrayed here as far as the osmolarity reports. You get 300, 700, greater than 1200, which is very, very concentrated urine because there's not much water in here. And then 700, 100, and then we start getting more concentrated urine here in the collecting tubule is what kind of sorts all this out at the end and kind of mediates it. And you know, the loss of water or the acquisition of water in this system is super important as far as like our hydration status. So if we're dehydrated, the kidneys are meant to conserve water. If we're overloaded, they're meant to get rid of that excess water. With kidney disease, of course, this does not work very well because the nephrons are not working very well for a variety of different reasons. We'll go into some of them a little later, which can either make you lose too much fluid and put you in a state of dehydration, which is high output kidney failure, or you can be fluid overloaded when the kidneys just don't want to work correctly, and that's actually a little bit more common situation. All right. It's just an extra slide. So when we talk about glomerular filtration, it's basically the pressure on the glomerulus into the Bowman space. So the pressure is what so that if you have decreased glomerular filtration rate, then you have decreased urine output and you have an increase in your blood urine nitric levels. So if you look at this this slide here, it just kind of shows you what electrolytes and solute you're losing. You're losing water here, you're losing chloride, potassium, calcium, sodium, and this is base, right? Glucose, amino acids, vitamins, urea, and chloride, sorry. And you're gaining here acid if you need it, ammonia, toxins, and drugs are coming in. You're still losing more water, it's getting more concentrated. You're going through the loop of Henle, you're losing more sodium, more chloride, more potassium, magnesium, calcium. And here you're adding in more acids if you need it, more potassium if you need it. And then here you're losing chloride, sodium, calcium, and water. And then in the descending or the collecting duct, you're losing sodium, potassium, chloride, calcium, base, acid if you need to, I guess, depends on how what's going on there. Urea and then more water. And then you're giving back in this potassium, hydrogen, which is the acid, and more ammonia. All right. So this is kind of amazing that this happens in this very short period of time. All right. Here is another really good YouTube video that I would recommend that you watch. I'm not going to show it to you right now, but you can take a look at that one. There's some really good videos out there if you don't understand this, and this is very complex. And for the most part, you just need to know that this is where sodium, potassium are really regulated, water is really regulated. This helps regulate blood pressure, which is part of your hemostasis process. That diuretics work on different parts of the glomerulus, which we're not going to get into because that's really beyond the scope of this class. And this is so important in regulating blood pressure. So here's just a little close-up of the glomerulus, which we, with the pressure in here causes the water and solute to be forced out into the Bowman's capsule, and then it's picked up by the proximal tubule. All right, so I talked about this a little bit already. Glomerular filtration rate is a calculated rate, and it decreases with age. As you get older, your kidney function decreases. So that's real important, especially as you look at older people, even with people in their 80s who have normal renal function for an 80-year-old is not normal renal function as we look at for someone who's 30 years old. So if you're thinking about medications and that sort of thing, you have to be super careful with them. Any kind of renal toxic drug, you have to be very careful with them. And so anytime that anybody's on medication, and you might want to do this too, is look up their medications, because you would be surprised how often this gets forgotten. And especially when you're talking about over-the-counter medications like your NSAIDs and things like that, if they're taking, naproxen or Motrin for pain, they could be definitely getting themselves into kidney trouble. Next, I'm going to start talking a little bit about kidney failure. There's acute renal failure and chronic renal failure. And I failed to put acute. There is pre-renal failure, post-renal failure, and intrinsic renal failure. I forgot to put the intrinsic on there. Acute renal failure is usually reversible. If it's not, then it turns into chronic renal failure, and then it is irreversible. Okay. So the biggest causes of chronic renal failure is acute renal failure, which kind of makes sense, hypertension, diabetes, and then kidney disease, such as polycystic kidneys, some kind of kidney obstruction, that sort of thing. The definition of acute renal failure is a sudden reduction in kidney function that results in an accumulation of waste products that are not supposed to be in your kidneys. So you'll see these people with high potassiums are the big kind of one of the big signs that we look for, and then fluid retention. Pre-renal kidney disease is caused by something that hits the circulatory system before the kidney. So, in other words, if you're dehydrated because you're vomiting, you have diarrhea, it's hitting your circulation system before you're actually getting to your kidneys. So your kidneys are not seeing the fluid that they should be seeing. Dehydration can also, if it's severe enough, cause hypotension, which can be a problem. So some kinds of medications that cause a decrease in urine. Hypotension can cause blood loss, can cause any kind of acute bleeding. Other things that can cause pre-renal problems are major surgery with blood loss, Severe injury, of course, that's blood loss trauma. Infections, burns. Infections, because they cause hypotension. Burns because it causes dehydration. If you have a blocking of or narrowing of the vessels going to the kidneys, this will cause a slowdown in the amount of blood getting to the kidneys at the rate that we would like it to get to, and that can cause pre-renal failure. And if this isn't corrected, this will turn into chronic renal failure. Heart failure, which causes decreased blood flow, and then liver disease. Okay. Post-renal failure is things that happen after the kidney or after the kidney, post the kidney. So the ureters, the bladder, the urethra, something in there that's causing urine not to be released in the normal way through your urethra. So if you have a tumor, if you have stones, if you have, it's got on here nephritis, cystitis, you've got a large prostate in a man, can cause post-renal failure. In babies, they have something called post-urethral valve syndrome, where basically they have a valve in their urethra that's just not allowing their bladder to empty. And if this has been going on long enough in utero, it can actually cause lots of issues, including something called prune belly syndrome, where the urine has backed up to such an extent that the musculature of the abdomen did not form correctly. The kidneys it backs up into that, and the kidneys become hypertrophic, and they lose a lot of nephron function. This can be either fairly mild and corrected with just a catheterization. The baby can be catheterized after birth, break open the valve, and then they're fine, or need surgery, and then some of these babies die. So it just depends how bad it is and how early on it's caught. And then this is, I just talked about the definition, this is movement of the urine out of the kidneys and out into the body, basically. And we talked about this, blood clots, cancer, anything that causes a disturbance in flow. Then you have intrarenal or intrinsic renal failure. I think this is what most people think about when they talk about renal failure, but we do have to look at those other causes. Probably in the ICU, we're probably going to see more pre-renal failure because of shock and trauma than you are anything else. This is a problem with the kidney itself. This can be from vascular disease. You have plaque buildups. You just don't have enough blood flow. The little arteries and arterioles and everything inside the kidney are blocked. There's a blood clot inside the kidney. There's a stone inside the kidney. There's injury to the kidney, some kind of trauma. You can also have like polycystic kidney disease, which is an inherited type situation where the kidneys just don't have enough nephrons to work correctly. And depending on if it's bilateral, unilateral, and how bad it is, once again, this can be anything from a fairly mild problem that they just have to watch medication use and just be kind of followed closely, to needing a transplant. And sometimes, depending on polycystic kidney disease, also is something in the newborn period that, if it's bad enough, can actually cause hypoplastic lungs, so their lungs don't develop correctly, and can cause fetal death or neonatal death. So part of the intrinsic renal problem is that they get acute tubular necrosis. And basically 50% of people with intrinsic renal disease have this. and it's just the death of the nephrons. So, like I said, acute problems where it's gone on long enough, or whether it's pre, post, or intrinsic, if it's gone long enough, then you're going to get death of the kidney. So that's why it's important to take care of some of these problems early. Like you think about pyelonephritis. The symptoms of pyelonephritis are similar to that of a urinary tract infection as far as frequency, pain, maybe blood in the urine. But they also have fever, and they'll have back pain. So if you look for CVA tenderness in the back, if you just kind of lightly tap on their back if they're complaining about pain when they have a fever and this sort of thing, that's something that needs to be treated pretty promptly, or you can end up with kidney damage. Acute interstitial nephritis, and this can be caused from allergies or infection. Glomerulonephritis is something that we see sometimes, and here's some of the causes of it. Antibiotics, anti-inflammatories, diuretics can cause this kind of thing. Then some sorts of cancer, of course, shock, chemotherapy, dyes, anything that affects the kidney. We think about the glycosides kind of antibiotics. That's gentamicin. All the myosin type things can actually, you have to monitor drug levels because they're nephrotoxic. So you need to be careful with anybody that's on an IC. Most of those drugs are IV drugs, so IV antibiotics, so they have to have monitored levels. Vancomycin's another one. But just kind of be aware of that those are something that has to be checked and can cause kidney damage. The reason that we check a creatinine level before someone has like a CAT scan or MRI with dye is the dye can be very nephrotoxic. It's really hard on the kidneys, and if someone does have to, if you do send somebody for a CAT scan or MRI that's going to include any kind of IV dye given, and make sure you instruct them to well hydrate before and after the procedure. And then again, polycystic kidney disease. Glomerulonephritis can also be caused by lupus. This is important. The big one that I see with this is kids with post-strep, and this is strep A, the normal stuff that causes strep throat, and they can had a history of strep, or sometimes they don't even have a history of strep, and then you notice that they're very edematous, their blood pressure is going up, and if you check an ASO titer, you'll find that it's increased, and ASO titers tell us whether there's been a recent strep A infection. The good thing about that type of glomerulonephritis versus some of the other types, including lupus, is that normally resolves itself over time. So just given enough time and support, that'll get better, where some types don't. Anybody with glomerulonephritis, though, probably needs to be seen by a nephrologist just to be sure. We do have 2 kidneys, and they are pretty amazing, but we don't want to lose them if we can help it. And then I already talked about vascular changes. So this is the stages for renal failure. So you can kind of read over that. And it talks about the changes in the creatinine levels and then urine outputs. So you can either look at either one of those things and kind of help your patients decide if that's something that they need to talk or be seen about. Risk factors for renal disease are advanced age. Like I told you, even a normal, healthy 80-year-old has some degree of renal failure. Your creatinine does increase with age, and and really kind of abuse. You know, we're pretty hard on our kidneys, but you usually have some sort of degree of vascular changes with elderly folks as well. Blood clots can definitely increase the risk for renal disease, diabetes, hypertension, heart failure, liver disease. And we've talked about all of those, so hopefully you can kind of see where those would come into play. The stages of acute renal failure is you have the initiating phase. Then you have oliguria, which just means that you don't have any urine output. It's usually very decreased. And then you can go into a diuretic stage. And this is kind of a high output failure stage. So you've got all this urine coming out and you're like, oh, well, we're over it. We're good. Well, not necessarily. And you have to really watch these folks because they can get into electrolyte trouble by just having too much urine. And then you have the recovery phase if you're going to get better, which is always a good thing. Another thing I'll talk about right here is a disease called renal tubular acidosis. And this is an inherited problem. And these folks can get into trouble, but it's very easily treated. So it's renal tubular acidosis. So they tend to just lose too much bicarb and they get acidotic. So all we do for these folks is we give them some bicarb, which, you know, you all know is it's like baking soda has got bicarb, sodium bicarb, and replace the bicarb losses, and they do well. Without the replacement, they actually will get very, very ill over time, and they become very acidotic, which is not a good state. Your body likes to be between a very narrow range of pH, and that's 7.35 to 7.45. You go one way or the other, and you kind of get into trouble. You don't kind of get in trouble. So if you have that disease, as long as they take the bicarb, they're fine. But some of the symptoms you'll see with these people is that they just aren't doing well, and they'll lose weight. They're not gaining weight. And if you check a urinalysis, you'll see that their urine is very acidotic or very basic looking. Because they're losing so much base in their urine. So if you kind of see that, you might want to check further. If you do a BMP, you'll notice that their CO2 levels will be very low, which is acidotic. And so you'll see this low CO2 level on their BMP, and you'll see a lot of base lost in their urine, and that alone can give you the diagnosis. Of course, this is probably something that primary care does not want to treat, but you would pick up on and refer. Okay, signs and symptoms. If you're concerned that someone may have renal disease, you're going to look for increased blood pressure, fluid retention. If they start having difficulty breathing, rales, bronchi, cough, sputum production, they just kind of look puffy, then be concerned about renal disease. The workup for renal disease is, first of all, you want to figure out if there's a reason why they could have renal disease. So, for instance, you might want to get that ASO titer. You're going to want to get a creatinine and a BUN level, your serum electrolytes, which I'm going to include your CO2, your urine electrolytes, because if your serum electrolytes are one way, you're going to want to see what the urine's doing. So, for instance, if your serum electrolytes show a high potassium, you should be seeing a lot of potassium lost in the urine, right? Because you're trying to get rid of that. But if you don't see that, the potassium in the urine is either normal or low, then you know there's something going on with your kidneys, okay? Same thing with sodium. It's a little bit harder to get a urine electrolyte panel. You have to collect urine. Usually it's 24 hours worth of urine to really get a good sample of that. But the serum electrolytes are easy. You're also going to want to do a renal ultrasound or CT or MRI or something like that to look at the state of the urine, and then doing a UA with microscopic. The UA is so simple to do, really. You can do one, it's it's just that dip UA type thing that we do. You should not see any glucose in your urine. If you do, then you've got so much glucose in the blood that the kidneys just can't take care of it, and so that's a diabetic state, which as we already know, can cause renal disease. You should not see any protein, because that protein shows that you're leaking something in the glomerulus along the way, because there's some kind of intrinsic problem with the kidney. So you really shouldn't see any protein. Caveat to that is if you've got a young, active person, a teenager who's very, very active in an active growth phase, they can have low levels of protein in their urine after activity. So if you get them to do a collect urine, first void in the morning, last void in the evening. The first void in the morning should be normal, no protein after they've rested. And then the last void in the evening, you should see the protein because they've been up working, running, doing sports, that sort of thing. But that is definitely something to, anytime you see protein in the urine, you need to at least think about the situation and what's going on and repeat it. You shouldn't see any blood in the urine. There are some metabolic or some genetic conditions where some people just leak a little bit of blood. They just call familial hematuria, and they just always leak a little bit of blood in their urine. It's a low level, it's small amounts, it's constant. They otherwise do fine, and you'll usually find a family history of the same thing going on. So just kind of be aware of that as well. Prevention. The biggest thing with prevention is really watching those nephrotoxic drugs, the aminoglycosides that I talked about earlier, gentamicin, vancomycin are the two big ones that we see, although there's others as well. Make sure people are drinking enough fluid to stay hydrated. They also want to kind of thin down the blood. You don't want the blood to be so thick that it causes damage as it's going through that glomerulus. That's another thing that you can cause an issue here. There's some people that, for whatever reason, just continue to make red blood cells when they don't need them. Basically, they'll have high hematocrits and hemoglobins, and this can cause renal disease as well. It's usually just treated by basically bloodletting. Every once in a while they take some blood and then they just kind of have the blood thinned out, but this is also something that is going to need to be referred to a specialist for workup. And you want to prevent kidney infections and then treat them properly. And you really want to do anything you can to prevent or treat hypo or hypertension promptly, because both situations can cause damage to the kidney. Here is another YouTube video, and I will show you this.
Do you want to do some exercising to see if we make your cardiovascular system healthier, stronger? Can it delay the kidney disease?
My doctor said I need to work out, lose some weight, and kind of eventually get off using meds and stuff. So that's basically my whole premise for coming here. My doctor took down my medication, the level of the medication, so that works for joy. I really do like coming here.
So the study was 12 weeks, and then they said if you want to, you can come and stay, because we're kind of trying to prove that renal rehab is a good thing for clients.
Research findings in our lab have shown that exercise improves the health of the blood vessels in kidney disease, but it also improves their exercise capacity, and they also report improvements in quality of life.
So there's a fairly big team that takes care of a kidney disease patient, including physicians, nurses, social workers, and dietitians. However, at current, the exercise specialist is not part of that team, and we really like to see that happen. So hopefully our program can show the benefits of exercise in those patients.
These young people are so good. They know what they're doing. They know how to bring you up slowly. They're very cautious, like, are you feeling okay? If you aren't, you can go down, but how about going up a little bit further? How about increasing the elevation a little bit? How about turning the speed up?
It's really a unique environment where the patients get to interact with both undergraduate students and graduate students, and it benefits both groups. They really learn a lot from each other.
They're standing here watching exercise. That's pretty boring. They talk to us. We kid, we laugh. They're so dedicated. So you get a lot of positive reinforcement because they're so good.
Okay, so I just wanted to show you that not only do we need to think about when we're treating or trying to prevent, which is the bigger thing we always want to do, kidney disease, we think about diet, we always think about medications, and folks want to go to medications first, but we really need to think about the whole person, and exercise being so important to make the total body healthier. So anyways, I hope this has been helpful to you. I do have some YouTube videos, things that you can look at here. This is a really good reference if you're interested in looking at that. Thank you very much. As I was just going to close this out, I just noticed this last slide I forgot to include. So some of the other symptoms are vomiting, diarrhea from dehydration, and also can be caused just from being sick. Weight loss, of course, we worry about nocturnal urination, so they're peeing a lot at night, the high output failure type thing. Real pale colored urine from very dilute urine. Or not urinating at all and having very dark urine. These kind of make sense, but I thought I'd include it since I put this slide up. There is another couple of kidney diseases we didn't talk about that might be interesting as well. One of those is diabetes insipidus. And once again, this can be a genetic disease. It also can be caused as a secondary disease state, but that's more rare. And this is really treated by the same medicine that we use to treat like bedwetting, DDAVP. And if you treat that, they do fine. If you don't, they get into all kinds of electrolyte troubles and dehydration. Anyways, just a side note there. Bye for real.